So today I want to talk a little bit about a body of research that we've done over the last several years that's related to trying to consider changing how people run to allow them to improve their symptoms and hopefully reduce their risk of further injury. So I want to share with you again some ideas related to that, but I want to start with a bit of a quiz for you. I want you to take a look at these two videos and tell me which individual, or sorry, it's the same person obviously, but which video does the person have pain in? So in one of the videos, she has approximately a 3 out of 10 level of knee pain. In the other video, she has no pain. Now, one video was taken about 3 to 4 minutes after the other video, so there wasn't enough time for any sort of analgesic effect from medication and other injections approaches to take effect. But do you see any differences in her mechanics that might help to explain her level of symptoms? So if you guess the video on the left side as being the side of pain, you're correct. So on the left video, she had about a 3 out of 10, and the right video was 0. The only difference between the two videos was how many steps per minute she was taking, so what her step rate was. The running speed stayed the same, so as a result of increasing her step rate, her stride length decreased, and she landed with different mechanics. So I want to describe some of those mechanics with you today. So the idea of trying to alter somebody's running gait, I'm very strongly of the opinion that there is no one ideal way for people to run. There's too much differences among us to think that there's a single way for all of us to run. Instead, what I want to do is think about how we can optimize or alter somebody's running mechanics such that it matches who they are. So if you look at the right side of this scale, you'll see that we describe the individual's physical status, so their strength, their flexibility, their alignment. Basically tells us how well they can tolerate different types of loads, how strong are they overall. Versus the left side of the scale tells us the types of loads that they're developing when they run. Do they run very hard, where there's lots of impacts, or do they run very softly? I think what we oftentimes see in our injury clinics is people who match this sort of area, where they run hard, and they also have many different types of weaknesses or alignment type issues. So our goal is to try to see if we can change both sides of the scale at the same time. If we can improve their strength while also reducing their level of loads that they experience when they run. I want to share this picture with you. It's one that I use quite often. This is the very first New York City Marathon. This is the starting line of it. Now, if you remember from 2 weeks ago, a week and a half ago, much different starting line at the New York City Marathon. There were approximately 115 runners. And you think about who those runners are and what they look like in terms of their strengths. Compare that to what you would see today, and it's much different. So in the 1970s, you could say, prior to the first big running boom, runners were very similar in their makeup. There were not a lot of the heterogeneity, a lot of the variability that we see in today's runners that we have to consider. And so when we think about trying to alter somebody's gait, what we're really trying to do is match and try to take into account that level of variability. So again, there's no single optimum form for all, but instead I think there are very key characteristics that we want to avoid. And those characteristics are overstriding, bounce, and compliance, and I'll describe each of those to you shortly. So this is an example of somebody who I would consider as being an overstrider and a bouncer. He moves up and down a lot when he runs, a lot of vertical displacement. He overstrides in the sense that his foot lands well ahead of his center of mass. And so there's many loads, as you'll see shortly, that are associated with running with this style. Excessive compliance, I think of in terms of stiffness or springy compliance. So there's too little stiffness. There's not enough stiffness. They're too compliant. They compress too much. And so you start to see these sorts of deviations that occur in their pelvis and in their knee. So what we've shown with some of our research is that by simply changing somebody's step rate, by increasing it by 5 to 10%, you can positively affect all of these variables. You can reduce the amount of bounce. you can reduce the overstriding, and you can increase stiffness or reduce their compliance. So I want to show you an example of an individual running with different step rates, the same running speed for all of them. But you'll notice on the left video is his preferred step rate at 160 steps per minute. And then we increase it by 5% and increase it by 10%. Now, do you notice anything unique about or how his running mechanics change? If you follow the red line on the wall behind his head, I think you can most easily see some of the key differences that occur. Notice how his head bounces a lot on the left, and as he moves toward the right, it tends to bounce less and less. More frequent bouncing, but less range of motion or less displacement. So when we look at the mechanical changes that occur with you when you run with different step rates, what we see at the knee, at the ankle, the knee, and the hip is that as you increase your step rate, running at the same speed, that's an important factor, you'll notice that the amount of mechanical energy absorption, as described by your joint powers, you'll see that there's a 10% reduction in total energy absorption with a 5% increase in turnover. And a 10% increase in turnover gives you a 17% reduction in joint power. Now notice which joint shows the biggest benefit, the hip, the knee, or the ankle. The ankle shows you the biggest benefit, the knee shows the biggest benefit in terms of energy load reduction. When we modeled this to look at the patellofemoral joint forces, again, what we found is that the patellofemoral joint forces decreased approximately 14% when you increase the step rate by 10%. So the joint reaction forces between the patella and the underlying femur are positively affected by this change in step rate. We took it a step further to look at the contact stresses on the back of the patella. Again, this is done through modeling, to be able to show that the mean pressures or the average pressures on the back of the patella decrease as step rate increases by 5 and 10%. So again, from a standpoint of what we commonly view as being a key factor in patellofemoral pain and anterior knee pain, this has a positive effect on the biomechanics at the patellofemoral joint. Now again, this was described on a per stride basis. But now if we think about if I increase the number of steps per minute, that means if I were to run a kilometer, I would have to take more steps to complete that kilometer. So to run a kilometer then is my cumulative load more than what it was prior. And so what we did is we again looked at what would happen if you took those reductions on a per stride basis and normalized it to a per kilometer. And again, you see a nice decrease in negative work performed at the knee per kilometer, up to a 15 to 27% decrease, depending on how much you change your step rate. The patellofemoral joint kinetics show the same, approximately 10% reduction with a 10% increase in step rate. So we've again then taken that data from biomechanics and then started to look at clinical trials data. So we have an ongoing randomized controlled trial right now where we have individuals randomized to receive Gait retraining. And those who receive Gait retraining with anterior knee pain have actually showed a very nice reduction in biomechanical loading by a 4-week follow-up. They're more likely to achieve a minimally clinically important difference in anterior knee pain. And they were able to return to their prior mileage at a much quicker level with fewer visits in clinic. So we only saw them a couple of times versus more than double that amount. When we further explored some of the muscle activity changes that occur with step rate, one of the key things we found is that the changes tend to occur during terminal swing. So it's not as if the muscle activity is reduced during stance phase, but rather during swing phase, the muscle activity changes. In fact, it increases slightly to reposition the leg in a more optimum position to reduce those loads at the knee and at the hip. And so in particular, you see the gluteus medius and the gluteus maximus show a nice increase in muscle activity during terminal swing phase. What this allows for then is the increase in activity of the gluteus medius reduces the amount of hip adduction or adduction that occurs during stance phase. So the muscle activity changes that occur during swing phase then have a positive effect on how the person lands and reduces the underlying or the resulting joint motions during stance phase. It also has a reduction in the hip frontal plane joint torques as well. When we look at the gluteal muscle loads, again, the effect is that you see a slight increase in muscle force production of the gluteus medius and the maximus, as well as the minimus during swing phase. However, during stance phase, there's a substantial reduction in the demands on these muscles. So again, if we go back to our scale in the beginning, what we're effectively doing is trying to reduce the demands on the muscles while we improve their strength so we achieve balance sooner. Notice as well, which of your gluteal muscles undergoes the greatest load during distance running? Gluteus maximus, medius, or minimus? Medius, by far. Gluteus medius has the greatest amount of load during the stance phase of running, followed by the minimus, followed by the maximus. Now, this is at common distance running speeds. Once you start to achieve more sprinting level speeds, then the gluteus maximus starts to increase a bit more. But at common distance running speeds, you'll see the gluteus medius having the greatest load being placed on it. Some of our follow-up work then looking at some of the modeling, and particularly to the piriformis muscle. Again, we didn't directly measure the force out of the piriformis. I don't think too many patients or subjects would appreciate us putting a load cell or a transducer into that area. So what we ended up finding was that the piriformis, the peak force required of the piriformis, reduced by 14%. And that reduction in peak force during stance phase had a 40% reduction in the eccentric demand on that muscle. So when we think about piriformis syndrome and common buttock-type symptoms that occur in runners, this has a very positive effect on reducing the demands on that muscle. So how do we do it? Very simply, we use a metronome. So this individual, this was our bouncer that I showed in the prior video, 144 steps per minute. He had chronic bilateral knee pain. What we do is we look at his mechanics, and the mechanics decide how much we change his step rate. There is no automatic ideal number for step rate, not that we found yet, but rather we find his mechanics and we decide what aspect of his mechanics we want to change. And so for this gentleman, we changed him 10% right off the bat, and that's the bottom video. So we increased him to about 158 steps per minute. And when we did that, his knee pain reduced in very short order. And he was able to maintain that running speed and actually increase his running mileage up to 30 miles per week, whereas previous to that, he was capped at approximately 10 miles per week because of his pain. So to facilitate this step rate change, we use a metronome, we set it to the step rate that we want, and we have the person match their foot strike to that metronome. And they're able to do that very quickly because it's a rhythm-based. If we gave them very specific targeted joint motions, it becomes more difficult. It's harder to learn, it's harder to understand. But a rhythm and following a rhythm becomes very straightforward for patients to learn. Now, admittedly, it doesn't correct all mechanics right away. There absolutely are fine adjustments that we need to make. And so we do a lot of verbal cueing as well, when necessary, to try to facilitate certain mechanics. We may use phrases such as try to land with your foot closer to your hip, or lean forward slightly when you're running, or try not to bounce as much. But we want to minimize the amount of verbal cues we give, because many times it's confusing to the patient, and it disrupts their ability to learn what we're asking. When we've looked at retention over a short period of time, just over a month, with only one, at most 2 sessions of training, people were able to reproduce what we had asked of them 5 weeks later with no intermediate training. They were able to recall what we had asked. Rhythms are easy to remember. It's something that we can naturally learn and pick up in with very little training. So when we look at the types of retraining strategy, and there are many out there, we've used a lot with step rate, but you obviously could use more of a foot strike conversion from heel toward forefoot landing, or midfoot, or pose running, or chi running, lots of different terminologies that are out there. I think the key thing in my mind is that the strategy needs to be one that reduces the symptoms. And that's the goal that I work with, the patients that I work with, is they're hurting. And so they want to be able to run with less pain. And so when I modify mechanics because I want to change their symptoms. I don't necessarily want to modify mechanics for the sake of modifying their mechanics. I want to change their symptoms. So if their symptoms don't change, then the modification is not something that I want to pursue. Secondly, I think it needs to be something that the patients can easily learn and they can reproduce on their own. They're only with me one time every couple of weeks. very little face-to-face contact. And so they need to be able to do this on their own, in the lab, in the clinic, outside on their own, on trails, whatever environment they're running on. They need to be able to reproduce what we're asking of them. And lastly, it's very important that it does not compromise their performance. I might be able to suggest that they make a modification, but that modification may require months of learning and months of preparation to be able to handle it safely. And then you always run the risk again of increasing the amount of oxygen they consume or reducing their running economy. So little work has been done in the stat area related to step rate. And what they found is that over a 3-week period of time, when runners increase their step rate, their oxygen cost or their curve associated with running actually shifted, such that the minimum oxygen cost matched up to their new training style. So they learned, they've adapted their running, their oxygen well, if you will, has adapted to their new running style. A more recent study just about a year ago, compared individuals after 6 weeks of changing their step rate by up to 10%, and found, and this was among recreational runners, so runners that ran about 15 miles per week. And what they found is that the oxygen consumption didn't change at all as a result of that modification. So they were not at any sort of a disadvantage, even for a short period of time. They were able to maintain their running economy throughout their training period. The other piece that I think is very critical to this is when we look at individuals over their training history and over their running career, we see a very natural increase in running step rate with experience. So if you go to individuals when they first start to run and follow them over the first couple of years of their career, you'll see a nice increase in step rate when running speed, even at the same running speed. So it tells us a lot that the individuals are learning how to better land and how to reduce those loads on their own. But in novice new runners, that's something we can facilitate. That's something we can help them. We can educate them very easily on making this simple change to save them a lot of time and probably a lot of knee pain along the way. We just recently completed a study looking at the possibility of using step rate as a way to prevent injury. Now, this is something that as a risk factor for injury. This is something I was quite hesitant about, and I didn't think we would see any sort of significant findings. But what we ended up seeing is that in the high school population, we followed individuals over the course of a cross-country season in high school, so over a 3-month period. And in particular, about 20% of runners experienced a shin injury, very common injury in high school runners. And what we found is that those who experienced a shin injury, those who had a step rate below 166 steps per minute, had a much greater odds of developing shin injury compared to those who ran over 174 steps per minute. Now, that's the first time that we've seen any sort of a predictive factor related to the absolute number that a person ran with. I was not one who believed we would find anything with this study. I thought it was going to be a wash, but my doctoral student was convinced, and it was something she wanted to do. Thankfully, I suppose she talked me into it, and she did a great job. And this study was recently published and has created a lot of interest in the sense that this is one of the first that's shown the possible predictive aspects of step rate. So then how do we determine the need for gait retraining? Again, I mentioned before, the number itself, we're beginning to get an idea of if there has importance or not, but many times we're looking at the mechanics of the individual itself. And so what are we looking for? Well, we generally focus on this initial aspect of landing. So this is your vertical ground reaction force when you run. It looks like a mitten. You have the thumb portion on the impact peak, and then where your fingers are being the active portion. Initial contact is the left, mid stance is at the midpoint. So during that shaded region, that blue shaded region, is the area where the loads are very high and it's a lot of negative work or a lot of energy absorption is occurring. We tend to focus on that area with our examination, but it's certainly not exclusively on that area. We try to look at the entire stride cycle, but again, with an admitted emphasis in this region. Part of the reason we do emphasize it is because of its association with different injuries. So for example, loading rate, impact peak, and such has been related to bone stress injuries and stress fractures. And we've recently shown that certain kinematic factors allow us to predict forces. How many of you measure forces on your patients in clinic? How many of you have force platforms in your clinic? Exactly. Very few do. Some do, which is great. Most do not. Same way in the US. Hardly anybody has force platforms in clinic. But forces are very important to understanding injury and injury risk. So if we can estimate forces based upon what somebody looks like when they run, because we can all see, we can all use video, we can all analyze mechanics, we can estimate these forces then. And so, for example, you can estimate vertical ground reaction forces by 3 key factors: a person's step rate, what their foot inclination angle looks like relative to the ground, so how much on their heel they are, and how much they bounce when they run. So if you bounce a lot and you land on your heel and you have a very low step rate, your ground reaction forces are much higher. Your vertical ground reaction forces are much higher. This also tells me then I can change these 3 factors and I will change my vertical ground reaction forces. So if I increase my step rate, if I reduce my foot inclination angle, and if I bounce less, I reduce my vertical ground reaction forces. Same occurs when we look at energy absorption at the knee. So the amount of mechanical load occurring at the knee based upon joint powers. Again, step rate is a common factor. Foot inclination angle again. And now the next one is how low they sink, how much knee flexion occurs during mid-stance. So those 3 factors allow us to predict or explain quite a bit of the variance associated with mechanical energy absorption at the knee. How many of you have mechanics like this in your lab as well, or in your clinics? We do. In fact, this is readily available in our clinic, but I never turn it on for patients. This is only for our research studies. And it's only when we want to injure people that we turn it on so we can then study how they became injured. No, just kidding. This will be my talk this afternoon on hamstring strain injuries. This gentleman's running 20 miles per hour, so 8 meters per second, roughly, on the treadmill. And he's doing quite well with it. Our record is about 9 to 9.5 meters per second on the treadmill. So again, this is our research data, but this is our clinic practice, a simple video camera, a 2-dimensional video camera. Now, there are certain specifications you need. High-speed video becomes very important. You need to make sure that you have a high frame rate, at least 120 frames per second. Becomes very critical to understand the mechanics well. And there are obviously other factors you have to consider, such as making sure you don't have perspective error and parallax error and fisheying of the lens and so forth. But you can do a very good job with a simple video camera, provided you follow certain rules. So we recently published this paper a few months ago in the Journal of Orthopedic and Sports Physical Therapy that we looked at, we described a standardized video analysis for running. So what are some key factors one can look for in their patients that would help define somebody who overstrides, who bounces, and who shows excessive compliance? And so in the appendix of this paper is a full review of all of the different measurements that we used, how we measure it, and how you can easily obtain the same images from a video camera. So I want to share one case with you. This is one of our our collegiate cross-country runners at the University of Wisconsin. She was a very good high school runner and was able to run about 30 to 35 miles per week in high school. When she got to college, she wasn't able to compete for the first 2 years because she was injured chronically. As soon as her mileage went up to about 70 miles per week, which was the typical expectation, 70 to 90 miles per week, she started to experience several injuries. See if you can guess why she might have been injured. Do those look like solid, stable running mechanics for somebody who's going to put on that many miles per week, that kind of running volume? So she's running at a 6-minute mile, 176 steps per minute. But on the video on the left, what are some key elements that you notice? A lot of arm swing, a lot of arm motion, a lot of arm excursion, a lot of trunk rotation in the transverse plane. Her leg lands well out ahead of her center of mass, well ahead of her hip. Her foot inclination angle is very steep. Her knee is fairly straight at contact. If you look at the video on the right, the frontal plane video, you'll notice her pelvis dropping quite a bit side to side, a lot of motion through her lumbar spine. So a summary of some of the assessments we would look for is if we looked at initial contact in mid-stance, for example, we would estimate that heel to center of mass distance. We would look at the foot inclination angle. How far off the ground is their foot? What sort of an angle are you experiencing? Generally, more than 10 degrees becomes a point of concern for us. Less than 10 degrees and the loads are reasonable. They're okay. I'm not as concerned. Tibial inclination angle. How far off of vertical is this individual? This is a key measure that we look for in our high school runners. Again, stress fractures and shin injuries are very common among our high school runners. I want to make sure that this angle is as close to 0 as possible. Within 5 degrees, and I'm happy with that. We look at our knee flexion angle at initial contact. Again, approximately 20 degrees we look for. Very speed dependent, but 20 degrees approximately tends to hold well. And then the amount of anterior pelvic tilt can play a big role as well, especially as I'll talk this afternoon about high hamstring tendinopathies. This becomes an area that we look for quite a bit. Now again, we're looking at a 2D image. So to think that I'm going to measure this very precisely, I can't. I have quite a bit of error associated with it, at least 5 degrees of error. So I'm not worried about measuring it exactly. I'm looking much more at an estimate based upon visual examination of the video. If you look at the frontal plane, then we can look at how well the joints are aligned. Is the hip, knee, and ankle in a straight line? It may not be straight up and down, it may not be vertical, but at least they're in a straight line with each other. The amount of lateral pelvic tilt that the person demonstrates, as well as the amount of trunk lean that occurs. All right, now we'll take you through a full case. This is a person's history and physical. I want you to think through what would you change on this individual and how much would you change it given her goals. So this is an individual, 44-year-old female, who has left shin pain and knee pain for the past 8 weeks. Unknown cause, but felt it was related to running on uneven terrain on a recent trail run. No real medical history to speak of. Her goal, though, is to run a marathon in 4 weeks. You have 4 weeks to get her to the starting line and for her to complete the marathon. And oh, by the way, she wants to run in 2 hours and 17 minutes. Just kidding. No, that's not true. No, she just wants to finish the race. Her physical exam, normal strength, isometric testing shows it to be normal, manual muscle testing. Single leg squat mechanics all look good. She's able to control her body posture well. A little bit of arch drop. The medial longitudinal arch of her foot has decreased a little bit. Otherwise, things are looking pretty good. No tenderness at all to palpation. Poke around her knees, nothing hurts. It only hurts when she runs. All right, here's her walking video, so you can see what her foot mechanics look like. Again, generally, things look okay. There might be a little reduction in the medial longitudinal arch, but the more recent data would suggest that's not too critical regardless. If you look at her frontal plane mechanics, we're looking at how her knees, her hip and knee and ankle are aligned with each other. How much lateral pelvic tilt does she show? Things look pretty reasonable. From the side view, we start to see, again, a pretty pronounced heel strike pattern. Her knees are fairly extended when she contacts the treadmill. Her foot lands quite a bit ahead of her center of mass, and she bounces a fair amount given the running speed of a 9.5-minute mile pace. There's a fair amount of bouncing. So what we decided to do, given her symptoms and given her lack of physical exam findings, again, she looked pretty good. There weren't a lot of strength-related issues. We opted to modify her step rate just a little bit. We bumped her up by about 5% to see the effect it had on her pain. So we increased her to 174 steps per minute, keeping the speed exactly the same. And we did ask her to shift her point of contact. We wanted her to think about getting off her heels. That was the only verbal cue we had. That doesn't mean that she was going to be off her heels. Most people think they land midfoot and they're still on their heel. But we wanted her to at least try to facilitate getting off her heel. and to gradually do this over the next 4 weeks as she built her mileage or tapered getting into the marathon. So on the left video, you can see her at 168 steps per minute. That's where she had her pain. The video on the right, her step rate increased to 174 steps per minute at the same running speed. Subtle differences, right? Can you even see the differences? They're pretty minor. They're not dramatic. So what I'm going to do is I'm going to overlay these two images on top of each other so you can really appreciate the amount of change that we're talking about. So the picture on the left is her at initial contact, what her body posture looks like. The picture on the right is at the higher step rate, 174 steps per minute. Now again, we're going to overlay these two. The picture on the right will stay in color. The picture on the left will become black and white. And then we'll blow them up. And so the pelvises are overlaid with each other. So the thigh and the lower leg and the foot, you can see a subtle change happening. If you can see the colored heel relative to the black and white shadow of her heel, you'll see that the foot is landing closer to under her hips, under her center of mass. You'll notice that the tibia is a little more vertical than it was before, and her knee is slightly more flexed than it was before. Very subtle changes. We stopped there. Why? Because she immediately said, my knees feel better. That pressure feeling that I had is gone. I'd like to try this for a while and see how it works. I said, good, go give it a try for the next week. If the pain doesn't improve, call me and we'll make another modification, but I want to see how it goes. She didn't call at all until after she ran the marathon and said she did just fine, finished the race with no pain, was able to build her mileage back up into the race, and kept this modification. Now, I have no doubt that she did not run the marathon entirely with this higher step rate. I'm sure she reverted back to her old pattern at some point in time. But I think it's key, though, is that she could alternate between the two patterns, her old and her new, and that was enough of an unloading to keep the symptoms at bay and allow her to run through the race. So again, gait retraining is not the solution to all issues, but I think it's something that we're becoming much more understanding of, to the point that we want to start integrating it much more in our practice, our clinic care. Our runners clinic at the University of Wisconsin in Madison, we treat probably 25 injured runners per week. And we do a fair amount of gait retraining depending on how they present. We don't look at that runner and say, you need to have your gait changed, as much as where are your symptoms, and can we reduce the symptoms and by modifying your gait at the same time as we address the physical impairments, the physical deficits, the weaknesses, the range of motion limitations, and other issues that may be presented. So again, the underlying approach that we take really is to make sure that the person's strength, that their musculoskeletal status is always higher than what the running demands require. So we want to bias them always to be stronger than what running is going to require of them. It's something that we do with a lot of other tasks. We do it when we lift objects, when we teach people with low back pain to properly lift. We modify the mechanics to reduce the loads. Simply with running as well. How much you modify it can be a big difference. You make a big change, it's going to take a long time to get used to that, months, and you run the risk of re-injuring them or injuring them in different ways. So we try to minimize the amount of change we make with the goal that we can offset, or we can create this bias toward keeping them at a reduced mechanical demands during running. Thank you very much.